Bismillahirrahmanirrahim. My name is Dr. Ziaurman. I am a vascular surgeon and working at Aga Khan University Hospital. Today we are going to discuss how we can manage a patient who is having carotid artery stenosis but is asymptomatic. You will get often patients who come to your clinic with carrying an ultrasound report or CT scan report and showing a carotid artery stenosis. But when you ask the history, they never give a history of TIA or stroke or amaurosis fugax. And so this stenosis, which is shown, carotid artery stenosis, is asymptomatic. So how you are going to manage those patients? So it is a bit controversial topic, because when there is about 70% stenosis, it causes a lot of anxiety in the patients. They think that they are at high risk of developing stroke, and as a matter of fact, they are. There is about 1 to 2% annual risk of developing stroke if these patients are untreated. And when we look our studies, which is randomized controlled trials, we have level 1 evidence that these patients do benefit with intervention, carotid stenting, and that reduces the risk of stroke. But when we look deeply in those studies, ACAS and other studies, we found that those studies was done before the era of the best medical therapy. Means in half of the patient, antiplatelets were not given, and same was true with the statins. So these studies were done before the widely availability of the antiplatelets which we have, like aspirin, clopidogrel, and statins. We now know that best medical therapy is quite effective in reducing the progression of the plaque and also reducing the risk of stroke. If we balance what an asymptomatic carotid artery disease causes, it causes about 1% annual risk of stroke. And if we see on the intervention like carotid stenting or carotid endarterectomy, they also carry risk of 1 to 2%. So it is not beneficial to offer intervention to all the asymptomatic patients. But there is a selective group of the patient which is at high risk of developing stroke, and how to identify those patients and offer the intervention so that the risk can be reduced. So our approach in asymptomatic patient is now selective. We are not offering intervention to all of the patient, but in a selective patient. And the selective patients have a vulnerable carotid plaque. What is a vulnerable carotid plaque? Carotid plaque, occurs at the bifurcation, that is internal carotid artery, this is external carotid artery, this is common carotid artery, and the plaque develops at the bifurcation. And we know that a plaque starts as a fatty streak, then there is inflammatory cells, and then there is lipid core which develops. So if this is adventitia, this is cross-sectional area of the vessel, and it shows adventitia, this is the media, and this is the intima. So the plaque stored in the subintimal space in the form of fatty streak, and with risk factor, it gradually increases in its size. So the plaque can be of two types. One is the soft and one is the hard or stable plaque. Hard or stable plaque have calcification. It has thick wall, and there is no hemorrhage in it. These plaques are at lower risk of developing stroke. You know that the stroke occurs when there is a disruption of the intima, and that actually let the platelets to come into the subintimal space, that releases some factors that causes the platelet clog, that activates the coagulation pathway, which is intrinsic and extrinsic, that leads to in situ thrombus. And when this thrombus embolize, that emboli goes into the end arteries of the brain, and that causes infarct of the brain, and that patient can present either as a transient ischemic attack or stroke. So here, if the plaque is vulnerable, means it has thin capsule or intraplaque hemorrhage, or it has disrupted wall, this is the plaque which is at high risk of developing stroke. So our approach is to offer intervention only in those patients who are having these vulnerable plaque. We are very fortunate that we are living in an era where we have investigations which can quickly identify those patients who have vulnerable plaque. We can use ultrasound, we can use MRI, and even we can use PET scan. Although they have some limitation, but in most of the patients, they are able to identify features of vulnerable plaque, and then we can counsel those patients. Thank you for that.